une session très américaine avec trois orateurs américains et vous allez voir de grande envergure puisqu'on va évoquer avec eux finalement dans la suite de ce qui a été évoqué ce matin, il y a un véritable fil rouge, vous voyez, un fil conducteur sur ce qui a été dit sur l'état des lieux de la situation, notamment par rapport à la problématique opioïde et la stratégie qu'on peut y proposer et notamment les nouvelles stratégies. Alors justement, vous voyez, le titre, c'est Efficacité et accessibilité, où en sont les traitements addictolytiques et que peut-on en attendre. Et on va voir justement ce qu'apportent ces nouvelles stratégies par rapport aux points qui ont été évoqués, soulevés ce matin, et pour lesquels, effectivement, on a besoin d'avoir des réponses pratiques, pragmatiques, pour finalement enrayer les problèmes qui sont des problèmes de grande envergure. Alors, nous allons avoir dans une première présentation, Michelle LOFWALL, qui est psychiatre et qui travaille dans l'équipe de Sharon Walsh à Lexington, qui connaît très bien, bien entendu, cette problématique des opiacés, qui a beaucoup travaillé sur la buprénorphine et qui va justement évoquer donc l'expérience clinique avec une formulation de buprénorphine à libération prolongée flexible, hebdomadaire, mensuelle. Michelle, the floor is yours.
Thank you. I want to thank the organizers for the invitation. This is my first time at this meeting, and it's just been lovely. And the weather is gorgeous compared to Lexington, where it was 95 degrees, and we're in the midst of a drought. So it's beautiful. I'm excited to share with you some of the data on flexible weekly and monthly prolonged release buprenorphine. My disclosures, so I'm a consultant, or I've been a consultant for Titan, Braeburn, and Camarus. And the three studies I'm going to tell you about today were funded by Braeburn in support of their application to be approved in the US, Europe, and Australia. So this is a weekly and monthly subcutaneous formulation of buprenorphine. It can be injected in 4 different areas of the body: in the arms, in the upper thigh, in the in the buttock upper area, right below the belt line, and in the belly, about 5 centimeters away from the belly button. It is stored, it doesn't need to be refrigerated. It is still a controlled substance, so you need to store it in accordance with your local policies. And there's 4 different doses available weekly, and 3 different doses that are available monthly. These correspond to a dose range that go up to about 24 milligrams of Subutex equivalents every day. And what it does is it really gets rid of the daily peak and trough that you would experience with taking a daily sublingual, and so that you have a nice, flat, steady state. With the weekly, the steady state's achieved within 4 doses. And if we can get the slides up, I wanted to show you some data from 3 different studies. The first I'm going to talk to you about is a phase 2 inpatient laboratory study that was done at the University of Kentucky, as well as Columbia in New York and Vince Associates. And this is a study that recruited adults with moderate to severe opiate use disorder. I'm just going to go back just to show you this real quick. And you can see there's these 4 weekly doses and these 3 monthly doses. And that these is what is equivalent to about 8 to 10 milligrams of the sublingual Subutex, about 12 to 16, and then 18 to 24. These are the 4 areas of the body where the medication can be injected. And it comes in a pre-filled syringe with a safety device where after you let go of the plunger, the needle inserts right back up into this area so you don't have to recap it. It was approved in late 2018 in Europe and Australia and has tentative approval in the United States. But it's very small volume, so you can see all are less than 1 ml for both the weekly and the monthly. And when you inject it underneath the skin, water, when it gets into contact with the water, the solvent gets released, and you get this liquid crystal kind of shell formulation around the medication, and then you have slow release of the buprenorphine over that specified time interval. This is a new publication right from Australia. It's freely available. It's all about the clinical guidelines for the use of depot buprenorphine, both with the other monthly product that's now available and the weekly and monthly I'm talking to you about here. And this is the reference ranges to the sublingual buprenorphine subutex. And so I just am highlighting the pharmacokinetic profile of what's equivalent to about 16 milligrams sublingual. Here you can see the C-min, C-max, or C-average and C-max compared to the weekly. There's your C-average. So you can see there's less of that, it's a tighter range between your C-min and your C-max. And then here you can see the monthly equivalent. So if you're going from weekly to monthly, you can see you would go from about 24 milligrams of the weekly to 96 of the monthly. So when we're thinking about all these advantages, I'm a psychiatrist, so I always think about the advantages with patients who have severe mental illness and who are non-adherent to their antipsychotic medication. And so there's some similarities there. Is there a benefit to just overall adherence? So is the patient going to be more likely to take it? And if they take it, are they going to then have better treatment outcomes just because they're actually adherent to the medication? But there's other questions that we have too, like just having a sustained buprenorphine blood level with individualized dose options have benefits in other patient populations like pregnancy for both the mom, fetus, and the baby. And NIDA is funding a study through the Clinical Trials Network that is going to be looking at just that. Are there benefits for those without this reliable daily access to medication, such as in the United States in many jails and prisons, there's a reluctance to give sublingual medication that has any abuse liability. So is giving a depot, is that going to be something that allows patients to have more access to treatment? And when we're using this medication, it's been studied without the need for giving additional sublingual on top of it. And so when doing that, does that help decrease concerns about misuse, diversion, and unintended pediatric exposures, which I think really influences, at least in the United States, our public policies. It really stigmatizes the patients and our treatments and limits access itself. So if we can start decreasing some of that stigma through improved modes of treatment delivery, that can have huge implications for our public health. So the clinical trials, these were all multi-site, and they were all among people who had opioid use disorder. The phase 2 I started to tell you about, this is in people with a moderate to severe opiate use disorder, but they don't want treatment. They're not looking for treatment. They do not want to stop using illicit opioids. And what we wanted to do was we wanted to evaluate the withdrawal suppression and the blockade efficacy of the weekly product. And so people who were adults not wanting treatment, they came to live in a residential research facility with us for about 3 weeks. They were stabilized on oral morphine, so that way they wouldn't get sick. They were taking 120 milligrams of oral morphine a day. And they were underwent this very interesting study design where after at least 3 days of stabilization on oral morphine, they go 15 hours without any oral morphine. And in that context, they are then randomized to receive hydromorphone 0, 6, or 18 milligrams intramuscularly in random order, and they'll all receive the same doses. This is, they're going to serve as their own positive control. That's what the purpose is here. And as long as they feel an effect to that, they're then going to get randomized to either 16 to 24 milligrams weekly injection, which is about 16 milligrams of sublingual buprenorphine equivalents a day, or to the 32 milligram weekly injection. And they'll then undergo those same challenge sessions just to see, are they now blocked? So the main primary outcome, and this was determined in conjunction with the Food and Drug Administration, was on liking of the drug. So you can see here that this is a scale that's bipolar. So 50 is neutral. They neither like nor dislike. And as they rate higher, 100 is the maximum score where they like the drug extremely, and 0 is dislike it extremely. So when they're on oral morphine, and then they have 15 hours of no oral morphine, they get placebo, 0 milligrams, and they really don't care for placebo. They don't like it, don't dislike it. But you get 6 milligrams of intramuscular hydromorphone. They're liking that, and then they're really liking quite a bit the 18 milligrams of intramuscular hydromorphone. And that's like equivalent of at least 120 milligrams of morphine, just to put the dose in perspective. So it's a decent dose. They're then randomized to either the 24 milligram weekly injection or the 32 milligram weekly injection. The oral morphine stabilization then stops because this is their medicine that they're on that's supposed to now block the effects of subsequent challenges to hydromorphone. And we wanted to make sure that they were blocked right after they got that injection. So a day to 3 days after are they blocked, and then right before they're due for another injection at the end of that 7-day period, are they still blocked? And so what you see here is that they really the scores of liking are still quite close to where they were getting to placebo before. So yes, both the 24 and the 32 did block the liking of hydromorphone. So this was a successful outcome. In terms of other outcomes that we looked at, there were plenty, but like for feeling really good and feeling high, the graphs look very similar to the liking that I just showed you. This is an outcome for mental state, drowsy, again, neutral to extremely drowsy. And you can see when they're haven't gotten the CAM 2038 yet, and they're just on that morphine stabilization, and when they go without the morphine for at least 15 hours, they're getting more drowsy when they're getting active hydromorphone. And then once they're on the weekly, they're no longer feeling the drowsy effects from those high doses of hydromorphone. What about opiate withdrawal? So, after 15 hours of no oral morphine, as long as the clinical opioid withdrawal scale was at least 8, a score of 8, which is about mild opiate withdrawal, the volunteers were given the injection without any initial sublingual dose of buprenorphine first. So this was a direct transfer onto the weekly product. And you can see that within that first day, oops, and go back. Within that first day, the withdrawal really goes down drastically. Let's go back to really not detectable scores, and it remains low throughout. We also measured buprenorphine levels as part of this study. So before they got their injection, you can see that their level is 0, as it should be, because they're just on morphine maintenance. And then after they get their injection, the first time point is 1 hour, and it's already detectable in their bloodstream. And then 4 hours later, you can see it's right below 2 nanograms. And it goes, and it has a peak within 24 hours, and then it slowly goes down, and then it goes back up again. So the results from this study show that there was good blockade of liking, high, and good effects, diminished craving and rapid withdrawal suppression without need for a sublingual buprenorphine lead-in, and there are no serious adverse events in this study. Constipation was the most common side effect. I'm going to talk to you now about this phase 3. This is an outpatient randomized clinical trial among people who did want to be in treatment. These are people with moderate to severe opioid use disorder, and they are between the ages of 18 and 65 and seeking treatment, can't be acutely suicidal, cannot be acutely homicidal, but they can, they can have depression and be stable and be taking SSRIs or other medications. So they can have other drug use. They cannot, though, be severely alcoholic where they need to have medical treatment of that alcohol withdrawal. They are, after meeting screening criteria, they are told, come back in withdrawal and we will start you on medication. And they come back, they're in withdrawal. Everybody gets an open label test dose of 4 milligrams of buprenorphine naloxone film. As long as they tolerate that, they are then randomized to one of 2 groups. One group where they're going to get active sublingual buprenorphine with naloxone for the rest of the 24 weeks of the study, and an injection of placebo, so that's the double dummy part, everybody's always getting both. Or they get randomized to placebo sublingual and the active injection of CAM that is weekly, the weekly active product for the first 12 weeks of the study, or month, and then everybody switches to monthly injections for the last 12 weeks. So at the weekly visit, there's always drug counseling, there's always a urine drug test, there's self-report of drug use, craving, and withdrawal assessments at each visit. There are random drug tests scheduled at random between each monthly visit in phase 2 only. After 24 weeks, the study medication stops, patients are encouraged to enter into treatment, and there's a 4-week follow-up. So the primary outcomes. So the European Medication Agency was very nice and had a simple way of looking at the results. They just wanted to know the proportion of urine toxicology results that were negative for illicit opioids. In contrast, the US Food and Drug Administration wanted to see that both the weekly product and the monthly product were working together successfully, and so they required to have a definition of a responder rate where the volunteers had to have a no illicit opioid negative urines at 8 pre-specified time points at week 12, along with these time points here, at least 2 of those 3, along with a required negative urine at the end of the 6th month, along with month 4 and 5, and 2 additional ones here. So it's very, very stringent, you can see. In addition, the urine drug testing was very, very sensitive for the study. The testing had a lower limit of detection of 5 nanograms per ml for codeine, morphine, hydrocodone, oxycodone. And we're also testing for methadone and its metabolite, oxymorphone, fentanyl, and norfentanyl. So overall, just over 400 volunteers were randomized, 215 to sublingual, 213 to CAM. And you can see that they're just under 40 years old. Little over half are male, but there's a good proportion that are female, primarily Caucasian, a healthy BMI, mostly unemployed, and with some arrests, as we would see, this is typical. Primary opiate of use was heroin, over 70% in both groups, and then the rest were prescription opioids. Over half are using by injection, and a good number also have hepatitis C. At screening, fentanyl was already in the United States at this time. The study occurred at multiple different sites across the US, and so you can see just over 20% or under 30% in each group were testing positive for fentanyl at baseline, and that there was plenty of other non-opioid drug use at baseline as well, with cocaine and marijuana being most common. And baseline craving before they get started on the injection was high in the 70s, and withdrawal is at 12, which is right at that border of mild to moderate, with a standard deviation of just 5 to 6 in both groups. In terms of retention on medication, just remember it's double dummy, so everybody's having to come at the same time. The retention was very similar over the 2 groups on medication and in the study. And the average dose, while the dosing was flexible, so the target was 16 milligrams of sublingual and 24 milligrams of the weekly, but the clinicians could determine with the patient if they needed to have a higher dose or a lower dose. It wasn't fixed dosing. But where patients frequently ended up was at the dose that's equivalent to 16 milligrams of sublingual daily. In terms of our primary endpoints, this was a non-inferiority study because of that active sublingual control arm, and it did meet the criteria for non-inferiority. Right here you can see the FDA responder rate, that very strict definition where you had to be negative at the end of the study, at phase 2, and then again also at phase 1. And then the mean percentages of opioid negative urines with the European Medications Agency, you can see that it is percentages higher, but it's not statistically superior. This is not inferior. There was a planned analysis, so if there's very detailed agreement on what kind of analyses are going to move forward in these studies. And the first planned analyses after those primary outcomes was looking at the cumulative distribution function of the percent opioid negative urines over weeks 4 to 24. So the idea that these are all patients who are new to treatment, give them a few weeks to kind of find what dose they're going to settle up on, and then let's look at what happens with their urine tests from weeks 4 to 24. This was tested for superiority, and what you see is that there's a difference here between the two groups that's really favoring the subcutaneous CAM over the sublingual, whereby there's a higher median percentage. So the median percentage, 50 participants have about 6.7% opioid negative urines compared to like just under 30% in the injection weekly and monthly arm. Just looking at the data over time with urine tests with self-report. So self-report can only hurt the results. So if someone has a urine test that's negative for illicit opioids, but they say to us, oh, we used, several days ago, then that urine test gets counted as positive, okay? And here, what you see, missing samples are imputed as positive, and you have these little asterisks mean that there's a significant difference between the two arms at that particular treatment week. So near the end of phase 1 on the weekly product, there's some statistical difference between the two groups favoring the prolonged release product. The circles are the random urine tests. That's just what that means. And initially here, you can see some difference between the two groups as well. In terms of craving's high before people are starting on the medication. In the 70s, this is a visual analog scale where patients are asked, since your last scheduled visit with us, indicate your worst or strongest need to use opioids. And it's between 0 and 100. 0 is no need to use, 100 is feeling a maximum need to use. And it really goes down very quickly. And importantly, right when people are making that transition from the weekly injection to the monthly injection, that these cravings remain low. So during that transition, people are remaining low on craving. And the same can be said with the clinical opiate withdrawal scale. During that transition, withdrawal remains low, and there's a rapid decrease in withdrawal. So as we went through the study and we're all talking and looking at things that are happening over time, it was clear that you have hospitalizations in any study, and when I was reviewing the serious adverse events and looking at hospitalizations and the reasons, that I was seeing endocarditis, osteomyelitis, sepsis, things that I see in our own hospital in our non-research patients. And I thought, well, maybe there's something else that's going on within a subsample that is the injection drug user. So this was not a planned analysis. This is just a secondary analysis where we just looked at the outcomes of the injection users. And so there were 114 injection users in the CAM group, 110 in sublingual. And you can see here, this is that the depot, the prolonged release medication, is doing a better job with urine negatives than with the sublingual. And we think that there's something about that. If you have the injection, you're automatically, you have that adherence compared to the sublingual. You still have to decide every day to take it or not. In terms of the adverse events, just to be brief, there was one death that happened in the CAM arm. This was someone who was hit by a motor vehicle crossing the street. And the hospitalizations, you can see there are more hospitalizations here sublingual to the CAM, but none of this is statistically different between the two groups. There were 5 drug overdoses in the sublingual arm and none in CAM. And I'll just say this was one sad case where one of the overdoses was in the context of someone going to jail and not being allowed access to their active sublingual medication. So they went into withdrawal while they're in jail. They then leave. They're in withdrawal. They self-treat with heroin, and they have an unintentional overdose. So it's another, I think, benefit of the long-acting injectables, is that they can actually continue their treatment even in places that don't want to allow them to do so. Otherwise, the side effects are related to the injection. So injection site pain, you can see there's injection site pruritus or itching, erythema. All of them were mild to moderate, though, in severity. Otherwise, these headache, constipation, nausea, these are common side effects of sublingual buprenorphine. And then there's some urinary tract infections as well. So overall safety profile, we think, was really quite similar to daily sublingual. Few serious adverse events. The drug overdoses, none in the injection, which is very positive. And the local tolerability with the injection site reactions, yes, they happen, but this is very good that they're mostly mild to moderate in severity. None were severe. So the last trial I want to tell you about is the open label trial. This went on for 48 weeks, and this was occurred in several European countries, as well as Australia and in the US. And you could bring your patients in to this study if they were already on sublingual treatment, and you could transfer them onto the weekly or monthly, or they could be patients that you're bringing into the study that are new to treatment and that you're just initiating them onto the weekly and monthly injection. This also allowed for flexible dosing, and you could use the 8 milligram weekly to do the dose adjustments. So if you needed someone to go up on their dose and they were, let's say they were getting a monthly injection, you could use that weekly injection to increase their dose until it was time for them to be due for their next monthly. And so here you can see the outcomes over time. So the majority of the people in this study were people who were already patients. So 190 were already people who were on sublingual buprenorphine, and then there were a fewer number, 37, who were new to treatment. Overall, this, N equals 227. You can see very nice retention at week 24, 82%, and at week 48, over 70%, which is very good. The clinical opioid withdrawal scale, similar to the other studies I've shown you, you have nice suppression of opiate withdrawal. You have nice suppression of need to use opiates. And in terms of opioid-negative urines, this is, there's of your patients who are already on treatment, they're already doing well. You're already seeing some of the benefit, and that is retained over time here. And this is your patients who are new to treatment. There you can see that it's taking them some time, but overall it's a nice trajectory going in the direction of these folks. But shows really the importance of time. In this open label study, they also asked a subset of the patients some questions about what their perspective was, particularly those that had been on sublingual buprenorphine, to see how they thought it compared to getting the injection. And so you can see that things that are green here say that they're increasingly important to the patients. And this color here, white, means that they're indifferent, and then these are the number of people who think that it's really not important at all. So there's a lot of things that were important to patients, and that was that it helps me to make sure I don't miss the medicine taking it. It helps improve my privacy as a patient, so they don't have to go to the pharmacy anymore. They don't have to have supervised dosing, which is common, I think, in Australia. It prevents accidental exposure to children or pets. It spares regular visits to the pharmacy, allows me to travel without carrying medication with me, prevents other people from having my medication, and doesn't require just taking a daily medication. And when asked patients about switching from sublingual to the subcutaneous prolonged release buprenorphine, the majority, that is 83%, rated it as somewhat better or much better compared to the sublingual. So taking these all together, these three studies really demonstrated that it was non-inferior to the sublingual buprenorphine naloxone on both the FDA and the EMA's primary outcome, was superior in the cumulative distribution function analyses on the illicit negative urines, was really well tolerated with a similar safety profile to sublingual, but with the addition of the injection site reactions, but those were pretty well tolerated and mild to moderate in severity. And really, you have these hints of offering some benefits to patients that patients like compared to the sublingual. So it seems like a very promising new treatment. And I get very excited about this because I think it can improve access to care. And we saw in the earlier talks that the United States has really dismal access to care. I think we were at 18% compared to you here in Europe, where you're just under 50%. And I think that this kind of treatment, which can really destigmatize the treatment and can be very helpful to our policymakers, which really influences a lot of our health care. We can possibly getting into settings where it wasn't previously available, like acute care inpatient hospitals, emergency rooms. And if we can really get patients talking about this, if they like it better, then they can help pressure the system as well. And then I think there's a lot of exciting research questions for us to answer as a field. Like what is the benefit to having a steady level? Is there really a benefit? And NIDA is going to be looking into this with several of their new studies that are going on through the Clinical Trials Network, like I mentioned with you with pregnancy. And hopefully this can really benefit our patients with public outcomes. And I just want to make some quick acknowledgments. We had over 50 site PIs, so I didn't have the space here to call them all out, but without them, we wouldn't have been able to do the research. All of our patient volunteers, I think, are probably the most important. I want to thank Camero, specifically Frederick Tyberg, the PhD, who's the chemist that has made the fluid crystals product available, and Brayburn, who really licensed the product and helped launch the studies in the US, Sunny Kim, who's head of medical affairs, and my University of Kentucky team, particularly Sharon Walsh and Paul Nuzzo, who's our statistician, and the National Institute on Drug Abuse. Thank you.
Thank you, Michelle. It was very clear. Very nice presentation. Y a-t-il des questions dans la salle? En train de réfléchir. J'ai des questions. I have some questions. So, thanks again for this nice presentation. Vous avez montré, donc finalement, on a donc un profil comparable en termes d'efficacité, en termes d'effets indésirables avec la forme bien connue, avec une plus grande simplicité finalement d'utilisation. Il est évident qu'on le voit bien, d'ailleurs, et ça c'est un élément je pense qui pèse très lourd, dans les éléments qui ont été indiqués par les patients, tout ce que ça peut apporter, car on voit bien aujourd'hui, entrer dans le traitement c'est une chose, y rester, c'en est une autre. Et c'est aujourd'hui effectivement le plus gros des challenges. Et on voit bien que nos patients, même quand ils ont de bonnes raisons de rester dans un traitement, c'est parfois compliqué parce qu'effectivement, il y a le poids du traitement, ce qui représente au quotidien, le poids de l'entourage aussi qui ne comprend pas toujours pourquoi effectivement il y a un traitement, et comme on dirait, de simpler, de better. Donc, du coup, vous avez montré donc l'intérêt de ces formes, avec en plus une flexibilité, puisqu'on a effectivement des formes hebdomadaires, des formes mensuelles. Alors là, vous avez montré, on va dire, les critères classiques. Et aujourd'hui, on voit bien que chez nos patients, il faut aller au-delà de ces critères classiques dans une prise en charge des addictions. Et notamment, on l'a bien vu déjà ce matin, dans ce qui a été évoqué, y compris dans la présentation de Wim, il y a un trait qui est omniprésent chez nos patients, c'est l'anxiété. Et là, j'ai vu notamment, il y a les troubles du sommeil, il y a des insomnies qui sont 2 fois plus fréquentes avec le traitement. Je voulais savoir si vous aviez une explication. Je voulais savoir si vous aviez évalué ces autres dimensions qui sont très importantes, et notamment la qualité de vie, qui est un point aujourd'hui qui est très important pour les patients, pour se projeter justement sur des traitements au long cours.
So we did not assess quality of life in these studies. There is an ongoing study that is looking at quality of life. We did not assess sleep. Agree, it's very, very important. And I think some of the things, there's so many different things that can affect patients' sleep. I mean, all the other substance use that's still going on, I didn't show you, the over time, what cocaine use looked like over time, and marijuana, and just the rise in methamphetamine, also just clinically all can not help with sleep. And then just also all the anxiety and worries that people have, which vary along the spectrum as well as, how am I going to get my medicine in the US, how am I going to pay for it, the doctor or the medication, that all can really adversely affect to someone's ability to stay in treatment and to not feel so anxious and stressed.
En fait, comme vous l'avez compris, vous avez évoqué effectivement les autres consommations qui peuvent éventuellement impacter sur le sommeil. Et justement, puisqu'on avait 2 fois plus d'insomnie dans le groupe avec la forme longue durée d'action, est-ce que ça avait changé quelque chose au niveau des autres consommations? Puisqu'on a évoqué les consommations d'opiacés, mais qu'est-ce qu'il en est des autres consommations hors opioïdes?
was not something that we'd not done the analysis where you control for, insomnia over time, but there wasn't a very large difference between groups on other substance use.
Est-ce qu'il y a des commentaires, des questions dans la salle? Alors, je vais encore en poser une. Alors évidemment, ça change la dynamique. Il est évident qu'aujourd'hui, avoir ce type de traitement, potentiellement, comment vous projetez justement dans la suite, dans la prise en charge des patients, puisque à partir du moment où on n'a plus à finalement s'occuper de certains aspects qui aujourd'hui quelque part pouvaient polluer, je dirais, la prise en charge lors des consultations, justement, comment vous envisagez la suite, comment vous verriez justement l'accompagnement, comment évoluerait éventuellement justement le métier d'addictologue par rapport à des patients finalement qui ont bénéficié d'un traitement au long cours qui laisse de l'espace pour faire autrement de l'addictologie.
So I think I've already started to feel a little bit of that. We have another monthly injectable already on the market, and so my job has already changed because of that in a very positive way, where there's interest in treating opiate use disorder among my fellow colleagues that previously weren't interested. So trying to teach emergency room physicians how they could potentially help someone. Like, is this a medicine that they could give to someone right away after they've reversed their overdose in the emergency room? Or is this something that they could start in the ER where they came in for cellulitis and they're saying they want help and they can't get them into a treatment right away? There's no bed, there's no office-based provider that has patient availability in the next week or 2 weeks. But could they give them a weekly or monthly injection right in the emergency room, protect them from having another overdose? Because so many of the patients overdose, they go back out, they use again, maybe even that same day, come back, overdose again, and then it can create a bad cycle of a lot of pessimism too. But now having this gives people more optimism. And so we are seeing that among clinical providers, and then there's an emergency room study that's being launched with this product as well in the U.S. through NIDA's Clinical Trials Network. So it's a lot more training and a lot more thinking, I think, too, like about having that smoother rise, like lower levels of buprenorphine. What does this mean for trying to transition patients who maybe are on methadone and want to try to get on buprenorphine? Is this going to make it easier for us? Like, there's all these kind of new questions that we have. But I think it's all really good and positive.
Yeah, it's very challenging and represents some very nice evolution of the field. Une dernière question, puisque la salle n'en a toujours pas manifestement. Vous avez montré les différences de concentration qui étaient obtenues donc, chez les patients avec des concentrations minimales, moyennes et maximales. Est-ce que justement il y avait des différences symptomatiques chez les patients en fonction de ces concentrations? Vous n'avez pas observé de choses différentes?
We had a PhD student that went and looked at some of the opioid blockade results and presented some of that data at CPDD, I think a year or 2 years ago, and showed that that you were able to get blockade and a decrease in liking and good effects at a range of doses. It wasn't that there was a very certainly clear therapeutic window. We had blockade with doses less than 2 nanograms per ml. So I'm not sure that I agree that there's like a therapeutic window for buprenorphine like there is for lithium and warfarin and other medications, because so much of it is it's highly variable still between people, and then what it is that they're using on the street was also going to impact your level of blockade that you may need.
Et ça, c'était vrai aussi bien pour l'aspect thérapeutique que pour les effets indésirables?
So we did not see a clear dose relationship.
Okay.
But it's hard to look at. Well, it's easy to look at in the phase 2 because it's dictated that you're on 24 or 32. So that's easy. And
but the numbers in each group would be, no, there wasn't any statistically significant difference, but you'd need a very large number of patients to see that.
Thank you very much. Merci beaucoup à Michel. On va passer la parole au deuxième speaker. Alors, nous avons Walter LING et Vigen Adipeli. Alors, Walter LING n'a pas pu venir, n'a pas pu se joindre à nous, mais très gentiment, il nous a adressé une vidéo qu'on va donc écouter juste avant votre présentation.
Greetings from Los Angeles, friends. I'm sorry I cannot be with you in person, but I wish you great success in your meeting. Vijay will present the full study, and I'm certain he's going to do more than great justice to the content. For me, the central message of this study comes down to answering one of the most frequently asked questions in every meeting of this kind, which is, we know buprénorphine helps our patients, but how long do we have to treat them before we can think about taking them off the medication? This study provides us the first indication about when the time comes. It turns out that a year of continuous treatment is about the time when we can begin to think about taking patients off the medication. It does not say it's the optimum time, but it gives us the beginning point to think about. This study shows that patients who have undergone a 12-month treatment, takes a full year of treatment with buprénorphine, about half of them have a good chance of staying off drugs, even if they stop the medication. Now that means the other half will still need medication. But if you look at the patients who have done well, these are people who have become less preoccupied with their medications and with their drugs of abuse. They have become healthier and getting their life together in the sense of being more employed, use less health resources, and have made connections with their families and their friends and become a member of the society. So that is the central message of this study as from the perspective of a practicing clinician. I wish you success and thank you again.
Alors effectivement, vous voyez que Walter LING a déjà introduit donc la présentation. Donc on va laisser la parole à Vigen Adipeli pour justement ce point qui est très important, qui questionne très souvent les cliniciens, à savoir finalement c'est quoi la bonne durée du traitement. On vous écoute, merci.
Thank you. Good afternoon, everyone. I can't obviously emulate Dr. LING, but will try to do my best. We're going to talk about the optimal duration of treatment in opioid use disorder. And like Dr. LING mentioned, we are going to be looking through the lens of following patients over a long time after treatment. So a few disclosures before I go into the details of the study. Obviously, I am an employee of Indivior Incorporated, which manufactures, developed and manufactures and commercializes Sublocade, the long-acting buprénorphine that we're going to be talking about. Throughout this presentation, I will be referring to this as BupXR. From a regulatory perspective, BupXR has been approved for use in the United States, Canada, and Australia for the treatment of moderate to severe opioid use disorder. Regulatory filings have been submitted in the United Kingdom, Germany, for most, really all parts of Europe, as well as New Zealand and Israel. presentation objectives are to discuss the findings from at 12 months from RECOVER study. RECOVER study stands for Remission from Chronic Opioid Use, studying environmental and socioeconomic factors on recovery, during which I will also discuss the treatment patterns, the relationship between clinical, economic, and humanistic outcomes. Along the way, we will, like Dr. Ling was mentioning, we will look at, gain insights on what could be an optimal duration of treatment based on this cohort that we will be following. So a little bit about the study, RECOVER study. This is a study that we have followed patients after the BUP-XR clinical trials. A patient could have been dropped out, withdrawn, or completed a clinical program associated with BUP-XR. They would become eligible to participate in RECOVER study. And we followed them every 3 months. So there's a survey administration, which we used an online platform, as well as field-based associates, research associates, along with the UDS. The outcomes of interest go much beyond than substance use, the craving and withdrawal symptoms that we largely see within our clinical trials. We now have measured their lifestyle, including employment, their productivity, what happens to them from an access perspective. We also have measured their health, their physical health, their mental health, the quality of life, very important, as well as the community. Are you being a good citizen? Are you really not participating in crime? Are you really engaged with your life and back in community? So a full view of recovery. In Dr. Ling's words, he says, get off drugs, stay off drugs, and get your life back. There are various definitions of recovery, but at the end of the day, a patient trying to get their life back is what we will be looking at, and that was our aim for this study. A little bit about the study design. I'd like for you to focus on stay with me on the bottom. So we recruited 533 participants out of the BUP-XR clinical trial program, which had about 900 plus patients in the BUP-XR program. So we had about 60+% of the participants enrolling into RECOVER study. This study is the last patient came in for the 24 months just in February of this year. At 12 months, we had 425, and at 24 months, we had 397 participants. The study also integrates the clinical BUP-XR clinical program data. The study also has taken information about what happened to them before they entered the BUP-XR clinical program. So we have a good baseline of what happened to them even before they entered treatment. And then we follow the 24 months afterwards, during which time, both times, here and here, we use public data sets to validate the information that the patients are providing as a self-report, as well as through the UDS. And the data on substance use treatment, the policies in the states and the counties where participants live. This was all done within the United States, multi-site, and really 29 sites participated nationally in the United States across the board. Our first patient came in August of 2015, and the last patient came in February 2017. And as I mentioned, the last subject came out in March 2019. We are currently conducting the 24-month analysis, but what I will be reporting is on the 12 months findings. The baseline participant characteristics. So just to align you on this table, on the left side, you have the full cohort of 533 participants. On the right side column, you have the 425, which are at a 12 months assessment. what we are looking at are, these are your typical patients that you would see for opioid use disorder. They were largely male, white, predominantly younger population, 30 to 45 and below, as well as their education level. They're decently educated, high school and college degrees. And marital status, they're largely single or divorced or separated. And they were living in stable housing in the past 30 days of their report. Also, they had a history of injected opioid use. And as you can see, the cohorts at baseline and 12 months, they're very similar. So what's the clinical significance of 12-month analysis, the findings that we have at this point? So what we found out in the 533 participants, we observed nearly 51% of all the cohort remained completely abstinent and sustained abstinence, whether they have received 1 injection or all the way up to 12 injections or more during the clinical program. I want to reiterate once again, when we are looking at these are results after the clinical trial. That means these are findings after they stop the treatment. They are in the real world. They stop the treatment in the clinical trial, and they're in the real world. In the real world, one could get a medication, one could completely be abstinent, or one could be in between, depending on what happens. So that is what we are seeing right now. On the right-hand side, you see their weekly abstinence at each assessment. It's a self-report. And all of them maintain greater than 60% at each survey assessment. This is the abstinence they're reporting at each of the assessment. We also noticed the longer duration of treatment with Bupexar. I think it's intuitive, right? When you are on treatment, you should do better. But in our analysis, we are finding out that people who were on 12 injections have fared significantly better. Should not be surprising. And 3 out of 4 people who were on 12 injections were abstinent for a whole year. So the 12 injections, the longer duration of treatment with Bupexar has remained the most significant predictor of abstinence. This is the weekly picture. So just to align with you, what we are looking at is, this is the 0 to 2 months, 3 to 5 months, 6 to 11 months, and 12 months of injections. So they were on those number of injections. So everyone who is on longer duration is doing fairly well, and their abstinence rates are above 70%. And really, when you are on the 12 injections, your abstinence rates remain above 80%. So this is a signal that we observed. The opioid preoccupation, it really decreased over time in those patients who received at least 1 Bupexar injection. So in the 12-month, without opioid craving, 54% of them saying they did not have any opioid craving in the whole cohort at 12 months. And on the right-hand side, you're seeing the opioid withdrawal. Those rates actually get better over time when you have longer duration of treatment. So what happened to employment? What we found out in the employment cohort, the employment in this cohort, is that 44 to 50% of them engaged in employment from baseline to 12 months. And the reference mark that you're seeing is the data that we have from baseline before they started the clinical trial in the picture that I was showing you. So that was remaining at 35%. And please note, these data are not during the clinical trial. These data are 12 months after they stopped the medication. And they're in the real world. On the right-hand side, these are the number of hours the participants were working. And as you could see, those hours are ranging between 164 to 172 hours. And it's a monthly measurement that we got based on what they reported. And the reference is your 160 hours at 40 hours a week. We live in the United States, so that's what the 160-hour reference comes from. So what happened to the healthcare resource utilization? I mean, there's data out there when you are in treatment, the healthcare resource utilization overall, people do better. In this cohort, what we observed is on the left-hand side is the data that comes from the RECOVER study. 7% of them reported any emergency department visits, and about, again, 6% reported staying in a hospital overnight. That's a hospitalization. Even after 12 months, this is what we are observing. On the right-hand side is more of a reference. This is United States data from claims data. Obviously, as we all know, in the real world, the data indicates that there is a high utilization of emergency department and as well as the hospitalization. So what happened to their arrest rates? Their lifetime arrest, on the left-hand side is at the baseline when we asked these, the cohort, the full cohort, 55% of them said they had lifetime arrest. So that's a lifetime view. Whereas when we now ask the same question at 12 months after stopping the treatment in this cohort, they're reporting 7% arrest. So we did not stop there. There was a question about, well, what happened? Majority of the people in our bupXR clinical trial received 12 injections. So we asked the question, hey, what happened to those who received all the 12 injections? So this is a cohort of 212. So that's your denominator. And what we are seeing here is the light blue here is the pharmacotherapy. So during our clinical program with bupXR, there was an extension such study that was offered after the pivotal trial and as well as the safety study, long-term safety study. That is, so a majority of these people decided to roll into that extension study, and so we have 82 of them in that. And then 79 of them, 37% of them said they're not receiving any therapy. By the way, the 82 of them, the 39%, they had a choice to go and really be independent. However, they chose to participate in that extension study by their choice. It's not a clinical trial, a program-driven effort, or a protocol-driven effort. And then 21 of them self-reported that they were using some sort of pharmacotherapy after they left the clinical trial. And 30 of them said they were using some pharmacotherapy, but they were also in the bupXR extension study. So we want to make sure we capture all the information that we got within this cohort, and 212 is the denominator. So let's see what happened to the abstinence. The outcomes at 12 months. So on the left side, you have self-report past week abstinence. And in the middle, you have the UDS-based abstinence. That means based on the UDS. And on the right-hand side, you have both combined self-report and UDS. As you could see, people who received any pharmacotherapy or no pharmacotherapy, their abstinence rates are really, they're pretty high. Especially those who were not receiving any therapy, they are very high at 12 months. And they're not taking any medication. So this is the time, generally, I would pause and say, what is recovery? And looking at all the data that we have so far, 51% of all the participants demonstrated complete sobriety at 12 months after bupXR trials. More positive recovery outcomes with the longer bupXR treatment duration, whether in the full cohort as well as in the cohort that was receiving medication or not. Also, it was observed lower craving and withdrawal with longer bup-XR treatment duration, and there was sustained employment, low healthcare resource utilization, and low crime rate. And I want to go back and say, get off drugs, stay off drugs, and get your life back. And that's what we are seeing in this cohort that we continue to study. Yes, there are limitations. I like to report those. Many outcomes of the RECOVER study rely on self-reported data. We did use drug screens for abstinence outcomes. Participants did not receive OUD treatment, but knowledge of being in the study and being asked to complete surveys may have modified their behavior. It is possible. Participants were not randomized to treatment duration groups. This is become a real world. This is no longer the 300 milligrams or the 100 milligrams, the randomization we had in the clinical trial that obtained approval for bup-XR. So we took everybody, and there's no dose control or anything like that, and we said we want to measure their outcomes and see how they're doing. Are they getting their life back? So that was our primary objective for the study. Nearly half the participants in the 12-month duration group continued to receive bup-XR. I was mentioning that they did not, they chose to be in that program because the sponsor offered that program to them. But however, we are going to be studying those outcomes at 24 months to find out how they would fare. A few acknowledgements. I wish to thank all the study participants and investigators who took part in the RECOVER study. And special thanks to Dr. LING, who couldn't be here, but also the rest of the research team who has worked together on this study. And I would like to thank ATHS, the sponsors, and the chairman here for kind invitation and the opportunity to share the voices of the patients that we all want to get their life back. Thank you.
Merci beaucoup pour cette présentation. On a du temps pour justement échanger autour de tout ce qui vient d'être présenté. Est-ce qu'il y a des questions dans la salle? Oui.
Hello. Thank you for the presentation. I was a little bit confused by the numbers. It looked like the overall cohort that you presented had approximately 450 people in it. And then when you presented the breakdown by medication, it was only 212, of which 37% were on medication, and you show 60% abstinence. But if you think of it more as an intention to treat, using the larger 450 number, it becomes a much smaller percentage. Could you address that discrepancy in numbers?
So thank you for the question. The original cohort that we followed had 533 participants overall. At the 12-month assessment, we had 425. So in the study, we had a pretty close 80% retention over the 12 months and also the 24 months. The data that we were looking at from the perspective of who received 12 injections, that one was related to their participation in the bup-XR clinical program. They could have received 1 all the way to 12 or more injections. So what we did is, at the 12 months, we asked out of the 425 who we had, how many of them received all the 12 injections? And that denominator is 212. I hope that answers the question.
Encore une question dans la salle.
Hi, thanks very much. So during this second year when you were collecting the data, was this collected with online surveys? Did they have in-person meetings? And how would urine tests be done if they were online surveys, or did I hear that wrong?
No, thank you for the question. This was, it took quite an effort for us to conduct this study. we had 3 ways of gathering information. One is at the investigator site for bupXR. If the investigator is able to bring the participant back after the clinical trial, they would actually keep that patient and conduct those surveys online. So it is through an online platform. A patient would walk into the investigator site, they would go through the initial stages, and they are given the interface for the survey, and they go through that. The urine test in the investigator site would be done at the, by the investigator staff, right? Then there is a second one where we are able to have our field associates, research associates go and visit the participant where they live or somewhere discrete, like in a library or like, you know, any place like McDonald's or whatever place that they could go to. And at that time, they would be able to obtain the UDS just basically in a brown bag, and they would return that to the field associate. And the survey mechanism will continue the same, which is they would be doing that online at the computer.
And this was every 3 months?
Yes, sir.
Okay, thanks.
Une question de Jean-Pierre de l'OUED. En attendant que le micro arrive, I have a question. Évidemment, c'est une présentation qui est pleine d'espoir, puisque finalement, elle ouvre des perspectives très intéressantes, mais elle est même un peu surprenante, parce qu'on peut se dire, finalement, chez des patients qui ont des comportements avec des conditionnements aussi forts, après, finalement, une durée de traitement finalement courte, comment est-ce possible, finalement, que autant de patients restent abstinents et finalement dans quelque chose de très différent de ce qu'ils ont connu?
So I want to make sure I understand your question right.
Parce qu'on est en vraie vie, hein, comme vous l'avez dit à plusieurs reprises, on est en vraie vie, en situation réelle, où on sait qu'il y a des situations effectivement qui sont très challengeantes pour les patients, où potentiellement ça peut réactiver du craving, il peut y avoir des sollicitations. Et là, on sent que beaucoup de choses se sont atténuées, se sont éteintes. Et donc l'histoire est belle, mais justement, voilà. Donc,
Thank you. Thanks for repeating the question. I appreciate that. Treatment obviously plays a very critical role, and the nature of bupXR, which we did not go in detail here, bupXR has the ability to remain in the body for longer than the duration of the treatment itself, and that's all reported in the label. But also as a research team, that we observed that there's a behavioral modification that was happening. A level of control and the ability to regain their employment, as well as the family relationships, a better quality of life. This is a work in progress, but I can reflect on that based on the data that we are looking at. There is a modification that is happening in this patient population that is giving them the ability to regain their life. So treatment, of course, you're absolutely right. There are situations in the real life where employment may not work, and family relationship may not work, and the community is not supporting. All of those fundamentals could play, but in this case, there is a very, a front-end drive where the patient, the participant, the human being in the center is able to stand, solid. In other words, yes, the concentrations and the sustained concentrations, all of those things are working. So it's an overall comprehensive view that I believe is really making these results, these kinds of findings possible. But that's not to say, like Walter was saying, this is just the beginning of the long story. Life doesn't end at 12 months. And there are going to be a lot of different things that we will find out.
Une petite question complémentaire, Jean-Pierre, si tu me le permets. Est-ce que, justement, dans les différences que vous pouvez voir, puisque certains patients n'étaient pas abstinents, est-ce qu'il y avait des éléments qui contribuaient à ça, et notamment, est-ce qu'il y avait des comorbidités psychiatriques qui favorisaient le fait qu'ils ne soient pas abstinents?
Certainly, the medication would work. We would want the medication to work for everyone. However, there are challenges that these patients are, undergoing and really interacting within their environment. That's why one of the reasons we said we want to study their environmental and socioeconomic factors, the impact of all of that. In terms of the comorbidities, I mean, all the patients were pretty similar in nature. You know, as we saw, the comorbidities probably were not playing a big role, but certainly, you know, it is possible that we are still trying to find out what's happening to some of them that are not remaining in abstinence. We never thought, you know, we would see all of them, you know, this level of result where people are remaining abstinent after 12 months. However, now we are beginning to pay more closer attention to understand what's happening to them. So we are following them, and we have plans to continue to follow them even beyond 24 months.
Bon, merci Michel pour cette super présentation. Le clinicien que je suis, je pense que je ne suis pas le seul dans cette salle, qui a une longue expérience des traitements de troubles de l'usage des opiacés par la buprénorphine, puisqu'en France, nous l'utilisons depuis 1996, est très impressionné par ces résultats et même très surpris, voire perplexe, tellement ils sont contrastés avec ce que nous observons, nous, avec les traitements par la buprénorphine orale. La plupart de nos patients sont en traitement depuis des années, voire des dizaines d'années. Tous expriment, enfin une grande majorité d'entre eux expriment aussi le sentiment d'être un peu prisonniers du traitement, mais n'envisagent pas de le supprimer. Et même ceux qui parviennent, ils sont nombreux, à diminuer des doses, mais restent avec des doses faibles, même de 0,4, 0,8 mg, et ne redoutent et ne parviennent pas de quitter cette dose. C'est pour ça que ces résultats, après 12 mois de traitement, sont très impressionnants. Alors, ce que l'on peut observer, je dirais cliniquement et un peu empiriquement, c'est que les patients en traitement, on va parler de la buprénorphine, puisque c'est là le sujet, il y a d'autres traitements agonistes opiacés, là on va parler de la buprénorphine. Ce que l'on observe, c'est que quand même, pour un patient traité par la buprénorphine, pour un trouble de l'usage des opiacés, il apparaît à l'arrêt du traitement, si l'arrêt est accidentel ou une tentative volontaire d'arrêter, un syndrome de sevrage qui est inconfortable et qui amène les patients à ne pas vouloir donc arrêter le traitement. Et en outre, nous ne les encourageons pas tellement à arrêter le traitement, car nous craignons aussi que cet arrêt du traitement ne permette le retour d'un craving qui fasse envisager une rechute. Donc, clairement, c'est une remarque, mais ma question, est-ce que finalement le long-acting permet d'éviter, puisque l'efficacité pharmacologique ne va pas s'arrêter d'un jour à l'autre, mais va probablement durer, la diminution des taux plasmatiques vont être prolongés sur plusieurs semaines, probablement, ce qui permet d'éviter un manque, un syndrome de sevrage de la buprénorphine, comme ça serait le cas avec la buprénorphine orale. En tout cas, je ne sais pas ce qu'en pensent les collègues, Maurice, ce que tu en penses, mais ces résultats très impressionnants sont très contrastés avec l'expérience que nous avons, nous, des traitements par buprénorphine orale. Donc, une dernière question. Est-ce que la forme à libération prolongée permet d'éviter à l'arrêt un syndrome de sevrage? Deuxièmement, on sait que la dimension des conditionnements dans les conduites addictives est extrêmement importante. Et finalement, un traitement par buprénorphine orale quotidien, voire plusieurs doses quotidiennes, comporte aussi une dimension de conditionnement, et que des injections mensuelles permettraient peut-être d'éviter cette dimension de conditionnement qu'amènent des prises quotidiennes ou pluriquotidiennes. C'est beaucoup de questions, je suis désolé, mais c'est aussi des remarques.
Now, thank you. I enjoyed that because as a researcher, I see this from a different lens. And in our sample within this cohort, some of them received only 1 injection and 2 injections and they went away. But when we look at the entire cohort of 533, we had a 52 or 51% of them remaining completely abstinent. And some of them in that cohort only received 1 or 2 injections. So I want to observe this in a way that I put myself in the patient's role. Some people may not need long treatment. Some people may need long treatment. So it's a personalized aspect that must be taken into consideration. With regards to the treatment itself, within our own clinical trial data and in the RECOVER study data, we are noticing that those people, participants who were on treatment, some sort of treatment after they left the clinical trial, and those who were not receiving any treatment, the cravings were less. I did not show that data. It's in one of my backup slides. The cravings were significantly lower for those people who were not receiving any treatment. Why so? We think, as you mentioned, the conditioning effect, somebody trying to take a medication on a regular basis, probably will keep them in that environment. Now I'm going back to the environmental part of the RECOVER study. And those people, those participants who came out and they stayed clean, and the 79 of the 212 cohort, they were not feeling those cravings. They were out, and they were showing a better quality of life, a better employment status. They were showing a better citizenship. That's what I believe is happening. And just for sharing information, when we were presenting some of the data at CPDD, one of the doctors came up and asked me, this is incredible, just like you were mentioning. I can't believe this. You either is making up this data or it is a miracle. And my answer was, I'm not making up this data. I don't have answers to all the questions. But I think that these people are getting their life back. It's a journey that we have never seen before. And it gives me gratitude to be able to tell that story.
I just want to add, we unfortunately in the United States don't have the 0.4 sublingual. I have the same experience as you were describing, Jean-Pierre, where it's trying to get people off of the sublingual even when you're at really, really low doses, and we don't have the 0.4 tablet, so we're quartering like an eighthing the 2 milligram tablet with people. But we do have the 6-month implant that is, it's approved for people who are on the equivalent of 8 milligrams or less of buprenorphine a day, so it's kind of the opposite of where it's very low concentrations. And my experience with that, because it's been out on the market for several years, is that putting people on that that were previously very stable on sublingual is that they do feel different not taking that everyday medicine, and that they have to get used to not taking something every day. So it's like very clear that they are conditioned to just that daily process, even though they've been abstinent frequently, and that they really do enjoy not having to take something every day. And then we have been able to off-label decrease people's dose, inserting fewer of the implanted rods, because it's 4 rods, and you could implant 3 and 2 and 1, and then the buprenorphine can stay in the system for months afterwards, because I don't know how long, but that's what we'll do is when a patient no longer wants to be on it, we taper them down and then just monitor their buprenorphine, and they don't experience the withdrawal, in contrast to when I'm trying to get off a patient on 0.5 milligrams a day of sublingual, and then they have almost like panic attacks, a lot of anxiety, and they can't get off of it. Like the physical dependence that they still have is too difficult for them, and then they start to worry and crave. So I think the long-actings have a lot of potential to ease that transition for people.
Besides pharmacology, we know that there is a very strong conditioning and the patient have to relearn new strategies. And 1 year is very short when these people have a long life with the wrong strategies and they have to relearn everything, how to manage differently emotion, how to manage differently relationships. And only 1 year is very short, so that's why it's very surprising. But we want to believe it because it's a very nice story, and we hope that the population in which you work is representative of the patient that we see, and for who we have some difficulties sometimes to propose something else. So thank you again for your presentation, and now we will have the third speaker. But, je m'excuse d'avance puisque je vais devoir vous quitter. Je dois faire une présentation dans une autre session. Donc on a le plaisir d'accueillir Joshua Lee qui va nous présenter la naltrexone à libération prolongée pour les troubles de l'usage des opioïdes et de l'alcool, puisqu'effectivement on voit bien qu'il y a une communauté de voix. Et Marc Auriacon va nous rejoindre et poursuivra la présidence de cette session. Je vous remercie.
Great, thank you. Great to be here. I'm from New York City. Unfortunate news today, President Trump is still in office, and we still have a terrible opiate epidemic in the United States, as we all know, largely driven by illicit fentanyl and fentanyl-like analogs in the heroin supply. Most of what I'll talk about today is the use of extended-release naltrexone for opiate use disorder, but I will say a little up front about alcohol use disorder. Naltrexone, as opposed to buprénorphine, is interesting in that as a complete opiate receptor antagonist at the mu opiate receptor, it has been shown to be useful, of course, for both alcohol and opiate use disorders. So it's kind of it's dually used in the United States for both those things, sometimes in patients with both, but usually separately. So for alcohol treatment in the United States, our data would kind of argue for naltrexone, either extended release or the daily tablet as the first-line treatment for alcohol use disorders. And then it's a little more complicated using this product for opiate use disorders because it can only be used after detox and for relapse prevention. I'm mostly getting grants from the National Institute of Health, from NIDA and NIAAA. We do try and take drugs for free into our trials, and so I've worked recently with Alkermes, the manufacturer of Vivitrol, extended-release naltrexone, as well as Indivior for free drugs into some of our trials. So we've talked in the first two presentations about the monthly and, of course, weekly in the Braeburn CAM environment, injectable buprenorphines. Those are very new in the United States, and we've had monthly injectable extended-release naltrexone since about 2006. And so in many years before that in clinical trials, and in 2006 it was approved for alcohol use disorder. In 2010 it was approved for opiate use disorder. Most of the use in terms of the market share or where those doses are going per month in the United States, my impression is that it's mostly now used for opiate use disorder, and the use for alcohol is not as popular as it is for opiates. So it's a product that comes in a kit. It's a powder and a diluent, which is a water-based thing. You mix that up in the clinic with the patient, and then you inject it in the upper outer part of the butt into the buttocks, and you alternate sides each month. And it's a big intermuscular injection, about the biggest one we use in medicine. It's about 3 to 4 cc's of fluid. And so the gluteus is really the only place to put it. You could try and inject it, for instance, in the shoulder and whatnot, but it's just not as comfortable. It traumatizes the muscle a little bit. Usually that's mild and well tolerated when it's given intermuscularly in the glutes. It's monthly. We tend not to vary that too much. You can give it every 21 days. For instance, if someone's using it for a heroin use disorder, maybe towards the end of the month they've used heroin again or they feel like their cravings are increasing, You can also use it a little more frequently, about every 21 days. But the label says every 28 days. That's about what we stick with. Unlike the buprenorphine products we were just talking about, there's not a very long tail. So at week 4 into week 5 into week 6, if you don't get another injection, it starts to rapidly wear off. And so monthly treatment retention tends to be quite important, especially for opiate use disorder. We really get worried if someone doesn't come back every month for the next injection, if that's the plan. Usually, if they have fallen off the medication and then they come back in a couple months and they're using heroin again, you have to start the whole treatment episode all over, and you have to detox that individual before they can get naltrexone again. And that's very clunky, and that's very different than methadone or buprenorphine, which are far easier to use in the sense that if people have been using other opiates and maybe they were missing for a couple weeks, they were using heroin again, now they're back, they can go right back on to treatment with agonist medications, and that's not the case with naltrexone. This was, I'm sorry, can I go back? Back? Yes, laser pointer here. This graph was the pivotal trial done in Russia. It was the company trial led by Evgeny Kripitsky, who may have been at this conference before, presenting this kind of data, and it showed versus placebo in Russian heroin addicted persons who entered an inpatient facility. They did some detox, then they were randomized 1-to-1 to placebo versus injection. And over time, the active medication group had a lot more cumulative weeks abstinent through, again, self-report and urine tests. And that got its label in the United States for opiate use disorder. And the label reads, for the prevention of relapse following detoxification. And that's a different reading on the label than, for instance, buprenorphine or methadone, which are approved for the maintenance of opiate dependence, and there's no mention of detox on those labels. So this really is kind of a post-detox maneuver, or we've done, and I'll cover a bunch of studies, we've used it extensively in the United States in the criminal justice system, and that's not without its critics, but that is an environment where everyone is sitting around, they haven't used heroin for a couple weeks or a couple months. There's a lot of risk when people are released and return to the community of relapse. And this is probably a pretty useful medication for those kind of situations. Someone leaving a controlled environment, like a prolonged hospitalization, they've been in a mental health institution for a long time, or a prison or jail, then it tends to be far easier to use the medication. The person's already opiate-free, they can immediately start the medication. And so it tends to really hinge on kind of what the clinical scenario is in terms of ease of use and how feasible it is to think about using this treatment. To touch on alcohol briefly, this was a very poorly rendered graph. I apologize for the graphics, but this was the pivotal trial done in the United States for alcohol use disorder. And this was showing people over days out to about 6 months, and it was showing cumulative heavy drinking days. And in these trials, that's usually defined as 5 or more drinks a day, or in any one 24-hour period for a man, and 4 or more drinks a day for a woman. That's a heavy drinking day. And on 2 doses of extended-release naltrexone, the higher dose was the lower thing. There was a kind of a less steep slope up and fewer cumulative heavy drinking days, and thus it was approved kind of for the suppression of binge drinking, we sometimes call it, in the US literature, or heavy drinking overall. It wasn't creating a ton more people who were completely alcohol abstinent, but it seemed to be cutting down on heavy drinking. And it was dose responsive, so the higher dose they used in this trial was getting a slightly higher or better effect. I'm sorry the slide cut off there, but I want to highlight 2 recent trials that were not very well covered in the United States, but I think they're extremely important. This is linking the use of extended-release naltrexone for alcohol and for opiates among persons leaving prisons in the state of Connecticut and Massachusetts. It was led by Sandy Springer. Her name is up top, but it's cut off in my slide. And what she did here were 2 NIDA RCTs. They're different studies. This study here is for alcohol, These were all 100 alcohol-dependent persons about to leave prison, and they were randomized in a double-blind study to placebo versus extended-release naltrexone. And the primary outcome in this alcohol study and in this opiate treatment study, so these are opiate-dependent people about to leave prison, 2 different studies, 2 different cohorts, the same design, though, and the same outcome. And the outcome they were looking at was HIV suppression. All the trial participants in both trials were HIV positive. So the whole point here was to get you on a medication that would prevent, when you were released from prison, a return to heavy alcohol use or heroin use, and therefore prompt probably better adherence to HIV therapy, and therefore lower viral load, more viral suppression over time in both these cohorts. And so both studies panned out, and they were both wins, if you will, for extended-release naltrexone. Here was folks 6 months after prison with viral suppression of less than 200 copies. They also looked at viral suppression less than 50 copies, and it was significant, and you were more likely at 6 months to have acceptable and then maximal viral suppression if you were assigned to extended-release naltrexone. The same thing happened here from baseline to follow-up. More people were under 50 copies, so maximal viral suppression, essentially undetectable load, if they had gotten active medication versus placebo. And in the placebo group, again, this is opiate users leaving prison. They had fairly acceptable suppression during incarceration, and then 6 months out, that had gone the wrong direction, meaning persons not on active opiate treatment leaving prison then had worse and worse HIV outcomes, presumably because of the return of regular heroin use post-release. And that was the opposite trend, and people looked a lot healthier leaving prison and then returning to the community, and then they saw more and more viral suppression. That I am aware of, these are the only 2 randomized clinical trials with a approved medication for opiate use disorder or alcohol use disorder that have shown an effect on HIV viral suppression. You could probably show the same thing with buprénorphine or methadone in a opiate treatment trial looking at, during incarceration and then post-release. But the trials that we've done haven't really studied HIV in the way these did. And we don't have enough of these other trials with HIV secondary outcomes to take a guess at this. So there you have it. So extended-release naltrexone, one of the only 2 studies now you can point at that are very well done placebo-controlled randomized clinical trials are not looking at the proximal alcohol and opiate outcomes, but are showing effects, presumably from the addiction treatment on HIV outcomes. I'm going to leave alcohol studies and now talk about opiate studies. And just to kind of review some of the what I'm calling key publications, and then I realized that a bunch of them are papers that I have authored, so take that with a grain of salt, if you will. But the pivotal trial that we just covered, excuse me, going back, there we go, was 2011 Krupitsky. We did a small randomized trial in New York City jails that I'll present real quick. And that was kind of a demonstration of a model that then was marketed pretty heavily to correctional institutions in the United States by the manufacturer to kind of improve the uptake of this medication before people are released from jails and prisons. We also, at the same time, were doing a larger multi-site study, and that was done with Chuck O'Brien, who I know has a relationship to this study. This was, Chuck's kind of semi-retired. This was one of the last big multi-site studies that he led out of the University of Pennsylvania. That was looking at persons who were outpatients but under criminal justice supervision. In the United States, we often call that parole or probation. They were opiate users by history, but they currently could start the medication. Most of them were not actively using it at the time, but we thought they had a risk for relapse. And that was then an open-label 2-arm effectiveness study. I'll show one result from that. And then I'm going to talk basically in closing about two recent head-to-head studies, one from Norway and one from the United States, which was comparing extended-release naltrexone to buprenorphine film in both Norway and the United States. So they were two head-to-head studies. We call the one in the United States the XBOT study, and then a very similar design was done in Norway, and they had quite kind of complementary results, which I'll go through next. This was our small trial in New York City jails. We randomized people over here to extended-release naltrexone, and this group got no medication. We have a lot of methadone and buprenorphine in New York City jails, but these were men who were about to leave jail in New York, but they were not on methadone and they were not on buprenorphine, and they were not particularly interested in agonist maintenance. They had had a lot of experience with those medications before, but for whatever reason, at this time, they had not signed up for those treatments voluntarily, and they were kind of untreated ahead of their release from jail. What I'm showing in this is a urine test. So at baseline, everyone had a negative urine for opiates. And then over time, for instance, in the treatment as usual group, pretty quickly, about half the urines showed evidence of heroin use when we had them back for follow-up. There was a lower percentage of that among the extended-release naltrexone group, all of whom had been actively medicated before they left jail. So that was a small study, but the signal was pretty good that this was probably preventing relapse immediately after jail, which we know is a big risk factor globally and certainly right now in the United States for an opiate overdose and for death related to re-exposing yourself to heroin and fentanyl. Some more graphics there, which I think I just explained. This was the larger Chuck O'Brien study. It was 300 plus patients, and you looked a lot better in terms of relapse-free survival. This is not mortality. This is a relapse-free survival curve. So the higher the curve stays, the less people were returning to heroin or other opiate use. And this was a significant effect, and the difference between not getting anything and being encouraged kind of not to relapse over 6 months was the area between these two curves. That was the treatment effect of getting active extended-release naltrexone in this open-label 2-arm study. We also followed people from that same 6-month period. We followed them for a further 6 and 12 months, so a total of 78 weeks of observation. And what we found here was pretty much unlike what we were just talking about with extended-release buprenorphine. Nobody over here continued medication. We did not have an extensions phase, and the medication wasn't widely used, and it had just been approved for opiate use disorder. There wasn't a lot of availability for underserved, poor, and Medicaid-insured populations, so essentially nobody continued medication after week 26. And then these are urine rates testing positive for opiate use. And they caught up. Essentially, the group that had been doing better on medication then kind of normalized and looked pretty much the same as the group that had not received medication, suggesting that optimal treatment with naltrexone for this population was probably a little longer than 6 months, and also kind of showing that there was not some long tail of recovery post-treatment that a lot of people just started to kind of look like they would have otherwise when the treatment had worn off. Interestingly, there's been a lot of worry, though, if you end medication after 6 months, does everybody just go back to using heroin? And they do so without a tolerance because they've not been maintained on an agonist. They're coming back to heroin use if they do relapse with a low tolerance, and that would be dangerous, and maybe they overdose at higher rates, and that would be certainly counterproductive, we think. In this study, we tracked that pretty carefully, and so here's overdose rates through the active treatment phase of 6 months and also, though, out to 18 months later. We did not see any overdoses in the extended-release naltrexone group, and there wasn't any great differences in terms of mortality or fatal overdose between the two arms. So it's not to say that was a secondary outcome. We weren't trying to show overdose prevention effects in this study, but it didn't suggest the opposite. It didn't suggest that there was a higher risk of overdose when people were leaving active medication and then possibly relapsing. I'm now going to talk about the two head-to-head studies, and then I think I'll be done. This was in Norway, and it came out about a year and a half ago now in, I think, in JAMA Psychiatry. And Lars Tanum was the principal investigator. It was a multi-site study in Norway. People came into 5 centers. They were inpatient for a week or so, so they were able to start naltrexone at quite high rates. They were able to kind of keep them in a center and interested enough to detox and then start naltrexone, as opposed to buprenorphine, which was easy to start on anyone and they didn't really have to detox. And then this looked at, in a non-inferiority, in a non-inferiority design, they followed treatment retention over time. So this is a survival curve showing people in treatment. Again, not mortality or relapse-free survival, but just who's staying on treatment. And that was the bulk of the study. It was to show that the curves were quite similar, and they were more alike than different. And so the non-inferiority criteria were met. And this looked like an acceptable intervention compared to the gold standard of buprenorphine maintenance. Interestingly, in Norway, buprenorphine is not used in the office-based primary care setting as in France or the United States. And so folks in this study had to go to an opiate treatment program, essentially just like for methadone, in order to receive buprenorphine in Norway. That's standard of care in Norway, but it's an important limitation of this data and might have been a real advantage to getting randomized to naltrexone, where you don't then have to go to the addiction treatment program every day for directly observed therapy. They looked at satisfaction, they looked at urine rates, they looked at safety events. They didn't see any differences in overdoses. They clocked a little higher satisfaction if you were assigned to extended-release naltrexone. That might get back to all the logistics involved with daily observed therapy on buprenorphine versus monthly only with the injection. They did an extension study, and there they offered everyone essentially crossover, and they found, more to the point, that the buprenorphine was not as well liked in this Norwegian study, and probably because of the environment in which it was prescribed. They didn't get anyone to stay on buprenorphine, and most people wanted to stay on naltrexone, and a bunch of people from the buprenorphine arm jumped over and switched to naltrexone for this. They then did a one-year extension study. That showed retention, was okay, but it started to diminish month by month. And so at the end of it, they're down to, about 30% of the people still on drug about 12 weeks after, or 12 months after. Very similarly, we conducted this study at the same time, and we were talking occasionally with the Norwegian group. We all were kind of aware of these two studies. The NYU team, headed by John Rotrosen and Ned Nunez at Columbia and myself, as well as many, many, many others, conducted this study in the United States. It was the same thing. It was head-to-head. You're going to get randomized to either extended-release naltrexone or buprenorphine film. Thank you, Indivior. You guys donated the film for this study. We called this the XPOT study. It was brought to you by the National Institute of Drug Abuse Clinical Trials Network. And it showed one important difference to the Norwegian study, and then otherwise looked very similar to Norway. We also recruited from detox units in the United States, 8 of them. You would come in for detox not knowing anything about the study, and around day 3, say, you'd be sitting in the narcology detox center, or whatever the phrase would be here in Europe, and we would show up and say, hey, do you want to be in a trial where you either complete detox, like you were probably planning, and start naltrexone, or we'll flip a coin, and if you get buprenorphine, we can just keep you on buprenorphine. Either way, you're going to leave this detox center and continue on treatment for 6 more months, and we'll see how it goes. The primary outcome for this one was a relapse event, meaning a return to regular opiate use as measured by urines or self-report. And we called relapse positive. A relapse event had occurred if there was 7 or more days of consecutive use, so someone had gone back to using heroin, say, every day for the last week, or if for 4 weeks, and we had weekly visits, the urine was positive or missing, or you self-reported some use over each of those 4 weeks. But you had to do it 4 weeks in a row, so you could either drop out and we'd never see you, and then that eventually we would term a relapse, or you had to keep coming in regularly but show evidence for 4 consecutive weeks of opiate relapse. When we look at our intent to treat, this was a pretty steep drop-off where people started to meet the relapse criteria at higher rates earlier on if they had been assigned to extended-release naltrexone. So in this intent-to-treat analysis, buprenorphine was superior, and this was because when we looked at who was relapsing early, it was people who had never gotten on study drug in the first place. It was harder to get people on naltrexone because they had to finish their detox, wait around for 5 days or so on average, so that any opiates that were used during detox, we often use methadone in a brief taper for detox, or some of the sites use buprenorphine. 2 of the 8 sites didn't use any opiates, they just used clonidine to detox you. In any case, it was not a slam dunk to get everybody onto study drug. We lost about 25% of people early on. They never got study drug, and all of them had a bad outcome in terms of either kind of dropping out of the study, returning to regular opioid use, or we also counted it against them if they switched to buprenorphine or methadone, which was a healthy choice. That also, though, in this study contributed to a relapse outcome. They were back on a non-study opioid. So that counted against them. The slopes of those curves look very similar, though, and then when we looked at an as-treated analysis, typical of like a drug trial, that's everyone that got 1 or more dose of study drug as assigned. The curves look quite similar, and that was actually surprising to us. You know, I think it had been our clinical suspicion that naltrexone was probably second best, and people don't like it as much month to month as those maintaining on buprenorphine. We saw a little some of that, but we saw some of the opposite, which is some people don't love being on buprenorphine every day, and that's not universally satisfying to every single client, and so it's a mix. And if we were able to get people on drug, they seem to do about equally well on these very opposite types of therapy, a total antagonist and then the partial agonist buprenorphine. We looked very carefully at secondary outcomes. There's a thought that cravings might be better controlled on buprenorphine. That was not the case among people on drug. That's what these data are showing, and therefore with data in follow-up, cravings were about the same between the 2 drugs. Again, very opposite approaches to therapy, but control of cravings very similar. People have thought naltrexone makes you depressed. It's a blocker of the opiate system. Your endorphins aren't going to work. You're not going to like your ham sandwich. You're not going to want to kiss your kids at night. You're just going to hate life because you're dysphoric and you're on an opiate blocker. Depression ratings were no different between buprenorphine, which we know is often a mood elevator and kind of a good antidepressant. In this case, naltrexone was not really perceived as much different. And we looked at cognitive function in part to show people on buprenorphine long-term have excellent cognitive function. So this was an opposite hypothesis where we thought you might be a little more better at calculation, pattern recognition, kind of these simple cognitive tests, and there was no difference there either. And then in terms of overdose events, there was no difference in fatal overdoses between the 2 arms, and there was a little difference in terms of the total overall number of overdose events that was lower in buprenorphine, a little higher, 18 versus 10 in naltrexone. What that probably related to was a much higher overdose rate, not fatal, but non-fatal overdoses, so people would come back and tell us a story about having overdosed. Not among people on medication or immediately after medication, that was the same, but there seemed to be a difference among people who never got on medication, and a higher proportion of that applied to naltrexone, and that was more dangerous. And then when we did a back of envelope risk kind of thing of odds of an overdose event over Wiesket risks, among all comers, if you never got on medication and once you had stopped study medication, your overdose rates in this trial were higher, and that was pretty intuitive, that on treatment you do better. It didn't seem to matter which type of treatment in this study. Off treatment, or you wanted to get on treatment but you never got there, you dropped out of the program during the first week, those were the higher rates of overdose across those subpopulations. It's been an interesting time for naltrexone in the United States for this particular product. There was quite a bit of press leading up to some of these trials coming out that was quite negative, directed at this, this particular medication. I'm not sure my slides are going to work. They kind of, yeah, all right. The earlier slide showed all these kind of high-profile news reports that came out quite critical of the medication, questioning its use in general, its really kind of place in the field, its safety profile, and the marketing of the product to criminal justice entities, which definitely was taking place, driven by the sole manufacturer. The trials, the evidence, I think is a little more reassuring. You know, I have my biases as someone who's done a lot of these studies, but I think we've kind of shown that it's fairly safe and it's comparable that we understand to date in the data that we do have to a product like buprenorphine. It's probably helping people in recovery versus somehow short-circuiting that trajectory and not helping them. And it's essentially kind of consistent with its labels as an effective treatment for alcohol and opiate use disorders. And we don't think it makes people horribly depressed, but you still read that whenever there's a news article about this product. That's often brought up. I'm just pointing out here just some kind of handy facts about this stuff. The trick with naltrexone for opiates is, of course, induction. It's hard to do if someone is actively using heroin. They come see me in my clinic on Tuesday morning. I cannot put them on naltrexone. We got to talk about detox, stuff like that. So that means it's not first line. Whereas if they come in on Tuesday morning, I can write them a prescription for buprenorphine or send them to the methadone clinic. They can get medicated, you know, within a couple hours, and that's great. And that's why we love those medications, I think, as first-line treatment, particularly in outpatient settings. It's just much harder to start naltrexone in general. A lot of this stuff is just kind of practical tips, but it's less complicated potentially than any of the forms of buprenorphine. It's once a month. There's only one dose. There's only one place to put the injection. It is refrigerated. I didn't mention that before. Otherwise, it's pretty widely available where I practice in New York State in terms of insurance reimbursement and availability through my hospital. And I'm going to, I think, skip this stuff and be done with it. Thank you very much.
Merci, Dr. Litz, c'est une intervention très intéressante. On va passer la parole à Marc-Henri Arcombe.
Voilà, oui, bonjour. Donc, Maurice de DEMATTEIS a été appelé, intervient dans une autre session, et donc... Mais comme son rôle était de présider, avant de passer la parole au modérateur, donc cette communication, elle est importante et intéressante, comme vous l'avez vu, par rapport aux autres, dans ce sens qu'on a pu voir, c'est vrai que le naltrexone a, entre guillemets, une mauvaise réputation en alternative à la méthadone et à la buprénorphine. Mais quelque chose que l'on doit garder en tête, c'est que le pire, c'est aucun traitement pharmacologique dans l'addiction aux opiacés. Donc, comme l'a très bien dit Lee dans sa conclusion, ce n'est pas un traitement de première intention, puisque la praticabilité fait qu'on ne peut pas démarrer là tout de suite, comme c'est le cas avec la méthadone ou la buprénorphine. Par contre, pour les patients, quelle que soit la raison, qui ne suivent pas un traitement par méthadone ou buprénorphine, on doit faire beaucoup plus d'efforts qu'on le fait actuellement pour leur permettre d'accéder à la naltrexone au long cours dans l'addiction aux opiacés. Et on a encore du temps pour des questions.
Thanks, Josh. You know, I understand in the context of a clinical trial, when you're comparing two interventions, you need to do your intention to treat analysis and potentially do a per protocol analysis. Getting people onto the medications was the big challenge, but once they were on, as you showed, the sublingual buprenorphine and the extended release naltrexone did equally well by the definition of relapse. But you include crossover to another medication within the definition of relapse. And you know, from a real world perspective, as long as someone remains in treatment, I don't care if they switch from naltrexone to buprenorphine, buprenorphine to methadone, doesn't matter to me, they're still in treatment. So if you pull out crossover to another form of medication from your definition of relapse and reanalyze the results, do they play out any differently?
We haven't done that exact thing. It was a quirk of the protocol that if you switch from Vivitrol to Suboxone in any form, the study wasn't going to give that to you. It was then considered non-study opiate use, and you would get dinged for it. So if you did reanalyze that as potentially more success and less and more opiate abstinent, putting aside the issue of is bupe in the urine from the prescription or street bupe, whatever, it would probably make the naltrexone group look a little better. There was a little crossover at one site in suburban Maryland where they had a pretty active and well-known Vivitrol kind of treatment paradigm, and patients assigned to buprenorphine in a handful of cases switched. They refused the study buprenorphine, completed a detox, and then just went, you know, in another doorway of the same building and got Vivitrol. And they looked good, but they were no longer on buprenorphine. But it didn't count against them because their alternative treatment was not an opiate, and of course their urines were, you know, free of opiates. So you could reanalyze it. I don't think there was enough cases that it would sway the ITT results. But it's interesting to think about, and it's something going forward. There's a bunch of new trials launching about treatment retention, and some of them are going to, this is kind of the United States opiate funding world, are going to track, you know, your assigned medication, but should also, we think, carefully track all the other things people can opt into naturalistically. And you're right, you know, back to how do they look overall in their kind of global function. Doesn't really matter what treatment they're on. We're just worried about improved function over time.
Une question courte, réponse courte.
Alors, deux questions courtes. Dr. Lee, thank you for your talk. First question is, do you have experience of patients with long-acting naltrexone in real world, not in clinical setting or clinical trials? And what kind of patients are asking for this treatment? And the second question is, because it's a 1 month long-acting also, I mean, formulation, what are the arguments that you use to convince them to go with a long-acting versus a daily one?
Yeah. You know, in the alcohol world, we've had people just prefer it and come to us seeking it and ask for it, and they're not interested in a daily oral, you know, Revia or oral naltrexone. They would prefer the monthly injection. They may have tried both in the past, and they feel the injection works better for them. We'll just go with it. If we have it available, we're fine with that, and we'll put people on it. In the opiate world, we've seen some people who want to graduate from buprenorphine maintenance and get off buprenorphine, but then kind of have an insurance policy in terms of relapse prevention, and then they'll do extended release naltrexone after a period of buprenorphine maintenance. And then we've seen some, just like in these trials, who they're in jail, but they tell the jail staff they don't want buprenorphine or methadone, which again we have widely available in New York City, but they would like naltrexone. That's pretty rare, but we get some of those referrals to our center where we continue to treat them. And in our hospital detoxification unit, we see the same, where some people just, you know, prefer this as their kind of preferred first treatment as opposed to after buprenorphine or methadone. And then the question really is long-term retention. Particularly in opiate use, it's people do well. We do see different trajectories. One classic scenario is I feel good, I'm opiate free, I'm not taking methadone or buprenorphine. It's been, say, 3 or 4 months, you know, I'm cured. Look at me, I don't even feel the naltrexone because it's not psychoactive. I don't really know what this shot is every month, but the bottom line is I'm doing this now for the first time and I'm not using heroin. And they leave treatment essentially with the belief that a cure has taken place. And then they're back a couple months later and I put them on methadone or buprenorphine because they're using heroin again. And I can't easily restart the naltrexone. And then, of course, you know, in our most vulnerable populations, this affects all our treatments. You were doing well and then something happened. You had to go to Florida for 3 months, or you're in jail for 8 weeks, whatever. And then, again, you realize the kind of limitation of naltrexone, which is that it's just hard to restart if there's any opiate redependence and retolerance, and then you're kind of doing it all over again, you know, a year later. And then that's not a great feeling. You did, you know, we had 8 out of 12 months were really good, but the last 4 months were not great. But now a year later, we're in the same place as we started, you know, and that is a little different with naltrexone, I think, than buprenorphine, where as their outpatient physician, I just put you back on buprenorphine, we keep trying, but it's not kind of this, you know, demarcation between periods of doing very well and then kind of dropping out of treatment and then having trouble restarting treatment.
Merci beaucoup pour ces précisions. Il faut qu'on s'arrête. Profitez de la pause jusqu'à 17h. Jusqu'à 17h, on reprend et on est en temps, ce qui est habituel à ATHS, très important. Profitez de la pause pour continuer à poser des questions aux orateurs. Profitez aussi de la pause pour voir les posters. Toutes les communications orales qui a lieu dans toutes les sessions existe aussi pour la plupart en poster, donc ça vous permet de pleinement profiter de tout le programme. Et puis il y a aussi beaucoup de communications par poster qui n'existent pas, qui existent en tant que poster. Et joignez-vous à moi pour remercier encore les orateurs.